the type and subtype and type in ratio they were different. Yeah, there were two different types.
The main characteristic of proportion was the relation between numerator and denominator. The numerator was a subset of the numerator. Okay, and we reviewed the measures of morbidity. We had two main measures of morbidity: incidence and prevalence. Incidence considers the newly diagnosed cases, but prevalence considers the available cases at each time. We had two types of incidence.
Cumulative incidence?
Cumulative incidence, that was a kind of proportion. I mean that numerator was a subset of the numerator. And the other type of incidence was incidence density, which was not a type of proportion. Why? Because the denominator was person time. It was not the number of population. It was a mixed indicator that relates to number of population and the number of time that we have followed the population. Yes? And how about prevalence? We had two types of prevalence. Point prevalence and period prevalence. Exactly. And we studied about the relation of prevalence and incidence. That was a direct or reverse? Direct. Okay? Direct association was between incidence and prevalence. The other important component to form a prevalence was duration of the disease. Yes? Because prevalence depends on the incidence and also the duration of a disease. I told you that if a disease has longer duration, the prevalence would be higher, because during some years we have some incidents and they are cumulatively added to each other, and the prevalence might be higher. Okay? But in this session, we will review measures of mortality. Incidence and prevalence was where the measures of morbidity, the occurrence of disease. But we have some measures of mortality. Okay? Why mortality is important?
To know how deadly a disease is.
It is clear because all of us will try to postpone the mortality, yes, the deaths, because all physicians try to reduce the number of mortality among their patients. It is the ultimate objective of our career. Okay? So, to know the data, the clear data about the mortality in each community, and being able to compare these mortality rates with each other, we should have specific measures, such as incidence and prevalence that we have reviewed about morbidity. Okay. Okay. Please see this example. Assume that the number of new deaths of disease X in a developing country is 10,000 in each year, but 100,000 in a developed country. In which country we should take disease X into consideration more seriously?
We can't tell because we should see the population, right?
Mm-hmm. Very good. The crude number is not important. Why? Because we do not know the population that live in those countries. Okay? So, this slide shows you, thank you, the number of deaths, and here you can see the years. You can see that the number of deaths is increasing.
It's increasing or not?
I don't want to say about the rate of mortality from cancer among cancer patients. It is related to the total population. I tell you that the number of deaths due to cancer is increasing during
But
these
maybe
years.
the population is increasing, so we can't
Very
tell.
good. Population might be increasing. If, for example, the total population in this year and this year is the total number of population is doubled, and the increasing, you can see here that the number of deaths is 300,000. Yes, and here the total number of dying from cancer is doubled. If the total population is also doubled, the rate is stable. But if the total number of population is not changed, the risk is doubled.
So this should
Why?
be as a condition.
Yes. You cannot say anything about the risk of dying. In the previous session, I told you that risk is a kind of incidence. Incidence needs numerator and denominator. You should know about the population at risk. In this slide, you do not know anything about the denominator. You have just number of numerator, number of dying at the numerator of the rate. So based on this absolute number, based on this crude number, you cannot say something about risk. You should know the population at risk and put it in the denominator, and after that you can compare the risk of dying between these years. Okay? So, another example as the same as before. 1,000 deaths in women each year according to disease A, and 2,000 deaths in men according to disease B. Which disease have more mortality?
B.
Huh?
B.
All. I told you that based on the number of deaths, you cannot say something about mortality. Why? Because you do not know the population at risk. In disease A, population at risk is 10 million. So you can divide 1,000 by 10 million. And in disease B, it is 2,000. But the population at risk is doubled as well. So if you divide these 2,000 by these 20 million, the rate is
The same.
the same. So we should have some measures such as incidence and prevalence. The first one is mortality rates. What is mortality rate? It is total number of deaths from all causes in 1 year divided by the number of persons in the population at mid-year. Okay? As the previous examples, you should have the population at risk, and you should have of deaths and divide these two numbers by together and find the mortality rates. So the denominator in this rate is population, not sick population, total population. Okay? Sometimes we do not aim to address entire population. We want to work on a specific population. For example, men, women, or age-specific mortality rate. For example, mortality rate in infants who is younger than 1 year. Okay? Or, for example, mortality rate among elderly population who are over 65. So, we have different types of mortality rates. For example, sex-specific mortality rates, age-specific mortality rates, or cause-specific mortality rates. For example, mortality rates from cancer. How can you calculate it? Mortality rates from cancer. You should consider the total population, and consider the number of dying from cancer and divide it to the total population. It means cause-specific mortality rates. All of them are mortality rates. So in mortality rate, you should consider the population of interest at the denominator and the number of cases of mortality at the numerator. Okay? For example, if we want to have, what is this? Please see this example. Annual mortality rate from all causes for children younger than 10 years of age. So the numerator is number of deaths from all causes in 1 year in children younger than 10 years divided by the total size of these population. Okay? Is it clear?
Yeah.
Okay. The next measure is case fatality rate. What is case fatality rate? It means that from the population who have that specific disease, how many deaths are occurred. Okay? It means, for example, number of individuals dying during a specific period of time after disease onset or diagnosis divided by the number of individuals with a specified disease. Okay? Numerator. Sometimes we know about the date of disease onset, but sometimes we do not know anything about the disease onset exactly. But we can use the disease diagnosis date. What do I mean? I mean that, for example, for cancer, for breast cancer, we cannot identify the breast cancer based on pathophysiology at the beginning of disease. But we have the date of diagnosis. It might be 1 year after disease, 2 years after disease, based on the time that the patient refer to a physician. Okay, come to a physician for making diagnosis. So we use the date of disease diagnosis in practice. It is a proxy of disease occurrence. Okay? What is the difference between case fatality and mortality rate? You can see here the two formula. Total number of deaths from all causes divided by the number of persons in the population at mid-year and number of individuals dying during a specified period of time after disease onset divided by the number of individuals with the specified disease. What is this? Mortality rate or case fatality?
Mortality.
Mortality. What is this?
Case
Fatality. What is the difference between these two?
There is specific disease in the case fatality.
And you?
First one is general deaths and for the entirety of the population. But the second one, it's dying of a specific disease, and the
Very
denominator is of people who have the specific disease.
Very good. So the main difference is the denominator. The numerator is here, in here is the entire population at risk of dying from the disease, the entire population who are healthy. But here,
I have a question.
disease.
If we want to check the what's it called, case fatality of cancer, for example. However, we noticed that, for example, there are 10% of the people who had cancer and died did not die because of cancer. They died maybe due to an unrelated thing, maybe a car accident or something like that. Are they considered in the numerator or not?
No.
The cause of
For
death should be.
case fatality, it should be certified that the death is related to the disease, not, for example, random deaths, for example, car accident, falling, or something like that. Okay?
Another question. Maybe for someone who has cancer, people who have cancer, for example, they might be prone to fainting because they're weak. And someone who fainted
Or,
because of...
for example, infection or something like
Yes,
that.
and it wasn't because of the cancer itself that he died, but if he did not have the cancer, he would have been able to treat himself and it wouldn't have been a bad thing.
Yes.
Are they numerator or not?
Yes. You know, it is a very good question. We have a system for relating and for specifying the cause of death. It means outcome committee. Okay? And we have a unique system for coding these reasons of mortality. It means ICD codes. We have used these system for categorization, for labeling the disease, because we want to have a unique system and make the death reason comparable in each country. Okay, so based on the disease, based on the reason of the disease, the committee can certify that if this reason is related to the specific disease that we are targeting or not. For example, if a patient is immunocompromised and the immune system is suppressed in that patient, and he becomes infected easily with an opportunistic infection, okay, and he directly died because of infection, but the reason behind of this infection is cancer, so it is related to cancer. Okay, so committee, an expert committee, can identify the reason behind a disease for some cases that we have doubt on it. Okay, and we can certify that if the reason is related to that specific disease or not. Okay, so case fatality is a measure of the severity of the disease. Why? It is clear because if a disease is more severe, the fatality of that disease would be higher. Okay, so if I tell you that, for example, pancreatic cancer has the case fatality about 80%, it means that out of 100 patients, 80 patients will die during a year. But if I tell you that, for example, case fatality of breast cancer is 20%, it means that out of 100 persons who are suffering from breast cancer, for example, almost 20 will die. So the severity of pancreatic cancer is higher based on the numbers of case fatality that I have told. Okay? So the main important for case fatality, if we have intervention to improve, for example, the treatment in some specific patients, the changes can be clearly identified in case fatality. For example, if a new method of treatment is, for example, invented, and we treat our patients with new drug, we expect to have less case fatality after several years. Okay? The impact of new modalities of treatment and diagnosis can be translated in reducing the case fatality. Okay? How about proportionate mortality? What is this? Proportion. Do you remember the meaning of proportion? Proportion, the numerator was a subset of the numerator. It means that among all this, what percentage is related to, for example, a specific disease? Okay? Total deaths in the US in 2015, number of deaths from cardiovascular disease multiplied 100. Okay, so numerator in proportionate mortality is all deaths in the community. Okay? Could you make an example for proportionate mortality?
For example, in Iran, you said yesterday that the highest cause of death was for traffic accidents. So the way they figured this out was seeing how many people in Iran died, for example, last year, and then comparing to how many people died last year from traffic accidents.
Very good. If I tell you that almost 45% of deaths in Iran is related to cardiovascular disease, it means that out of 100 deaths, 45 is related to cardiovascular deaths. Okay? So it shows you the importance of each disease to produce death number among all diseases that produce deaths in your country. Okay? Please see this example. Assume a population of 100,000 people, of whom 20 are sick with disease X, and in 1 year, 18 of the 20 die from disease X. What is the mortality rate from disease X? Mortality rate. It is clear. Total population is 100,000 and mortality from disease X is 18. Okay? So it is is 20, and out of these 20, 18 deaths is related to disease X. So it means 90%. It means 90% of all deaths in this community is related to disease X. Okay? How about total mortality? It is cause-specific mortality rate, okay? Mortality rate from disease X is cause-specific mortality rate. But how about total mortality rate?
We need to see the total amount of people who died.
Very good. We cannot say anything about total mortality rate in this example. Why? Because we do not have the number of total deaths in that community. If I tell you that the total number of deaths in this community is 1,000, you can calculate the total mortality rate. You can divide 1,000 by 100,000, and you can tell that, for example, 1 person. Yes? 0.1%. Yes? Okay. Please see this example. What is this? Mortality rate from all causes in community A is 30 per 1,000, and in community B is 15. So mortality rate in community A is twice compared to the community B. Okay? And proportionate mortality from heart disease is 10%. What does it mean? Could you please explain 10%?
It means 3 out of the 30 people who died in community A.
No. This 10%.
It means that 10% of all the deaths in community A were from heart disease.
Very good. Very good. It means that out of 100 deaths, 10 is related to the heart disease. Okay? How about mortality rate from heart disease? As comments say, mortality rate from heart disease is cause-specific mortality rate. Am I right? Okay. What is the cause-specific mortality rate from heart disease?
You know the total number of people who are like ready with heart disease.
How can we find this?
We have to find this.
We know that mortality rate from all cause is 30. We know that 10% of this 30 is related to heart disease. You said, yes? Okay.
Should I continue? So 10% of the deaths of community A were from heart disease, which means 3 of the deaths were from heart disease. So the mortality rate is 3 by 1,000.
Very good. Very good. If we know that the total mortality is 30, and we know that 10% of this is related to heart disease. So the mortality rate from heart disease would be multiplication of these two to each other, so it would be 3. How about the community B? We know that total mortality is 15, and 20% is related to heart disease. So the multiplication of these two produces 3. So the mortality rate from heart disease would be the same. You can see that mortality rates are not the same. Proportionate mortality are not the same, but the mortality rate from heart disease would be equal. Okay? Please see this example. Here, sorry. in early period and in later period. Okay? Here you can see the causes of this: heart disease, cancer, all other causes, and all this. Heart disease has 40 per thousand, cancer 20, all other causes 20, and all this is 80. Okay? How about later period? Heart disease is doubled from 40 to 80, and these two are the same. So the total number of this increased from 80 to 120. Okay? How about proportionate mortality? Proportionate mortality means the proportion of heart disease deaths due to heart disease considers all this. Okay? So 40 divided by 80 means 50%. 25%, the result of dividing 20 to 80, and this is 25% as well. How about later period? The proportionate mortality of heart disease, 80 divided by 120 equals 66. Almost 17 and almost 17. Okay? Although the mortality rate from cancer and from all other causes has not changed, you can see, but the proportionate mortality has changed. Why?
Because the heart disease changed. Because the heart disease changed.
Very good. Because all of them are related to each other. Because all of them are different pies of a circle. So, if you increase this pie, these two pies are decreased. So, you cannot say anything about these two numbers. You cannot say that, oh, the situation in our country is better because the proportionate mortality of cancer is decreased. You cannot say this sentence. Why? Because proportionate mortality cannot say anything about the situation of a disease, about the risk of a disease. Okay? Because it relates on the role of the other specific diseases that are common in your country. Okay? If the proportion of one segment of the mortality increases, there will necessarily be a decrease in the proportion of some other segment. Please see this example. If all-cause mortality rates differ, cause-specific mortality rates can differ significantly even when the proportionate mortality is the same. It is this scenario. You can see community A and community B. Mortality rate from all causes. In community A is 20 and in community B is 10. Proportionate mortality from heart disease is 30%, and in this community is 30% as well. But mortality rate from heart disease, I mean cause-specific mortality rate, is 6 in this community because of multiplication of these two, and 3 in this community. Okay? It means that although proportionate mortality from heart cancer is the same, but the cause-specific mortality rate is different. proportionate mortality can give us a quick look at the major causes of death in each region, but it cannot tell us the risk of dying from a disease based on two examples that I have showed you. Okay? We have another important topic, potential life lost. Years of potential life lost. What does it mean? Do you hear about it previously?
So for example, if we say cancer causes 10 years of potential life cost, it means either it will, for example, cause one person to have his life shortened by 10 years, or maybe it will cause 5 people to have their life shortened by 2 years.
It is related to the early death.
Related to?
Early and premature death.
Aha, very good, very good. Please assume a disease in which you have mortality at the age of, for example, 20. It is related to the younger adult. And the other disease may produce deaths at elderly population at the age of, for example, 70. You may have 1,000 deaths from that disease and 1,000 deaths from that disease. Which is more important? The disease that produces at earlier age. Okay, deaths at earlier age is important, more important. Why? Because you may lose many years of production. Many years of productivity may be lost if you have disease and death, mortality at younger age. So, we can compare different diseases based on the years of potential life lost. As a policymaker, you may decide that which disease is more important to make intervention and to control it. So you can use this topic because the number of mortality and the rate of mortality would be the same for two diseases, but the importance of one disease is higher. Why? Because it produces deaths at earlier age. Okay? So, to calculate the years of potential life lost, you should know about the average age at that country. It means life expectancy. We say that, for example, in Iran, the life expectancy is 75, and it is increasing in the recent years to 68, I think. It means that each baby that was born, we expect for him or for her to live at least 75 years. It is life expectancy. So, if the standard predefined age is 75, an infant dying at 1 year of age has lost 75 minus 1, it means 74 years of life. Okay? It means that if he or she hadn't died, he would have lived at least for 74 years after that death. Okay? So, if you have, for example, 1,000 deaths, you should calculate years of life lost for each person, for each number of deaths, and sum up them together, add the numbers together, and calculate the number of years of life lost. And after that, you can compare different diseases with each other. Okay? Here you can see that 21 million years of potential life lost were related to all causes. Malignant neoplasms, 4 million. Unintentional injury, 10 million. Heart disease, 10 million. And for all reasons of death in each country. So based on this, you can prioritize your intervention. You can select the disease for having intervention, which is important and which is more effectiveness, I think. Okay? Because I told you that the total number of deaths is not important. The total number of deaths of 1,000 in age 85 is not comparable with the total number of deaths of 1,000 in age, for example, 30. Okay? Using this approach, you can consider age at death and also number of deaths. Okay? Here you can see another example. Why look at mortality? I told you that mortality is so important because it is the ultimate goal of living. Okay? And we want to postpone these events. Okay? But we can use the mortality information as a proxy of incidence, as a proxy of morbidity. What do I mean? I mean that in some situations, we can use mortality data as a proxy of incidence. In which situation, if we have these two criteria, first, then the case fatality rate is high. I made you an example of mortality rate, case fatality rate from pancreatic cancer. I told you that almost all, 90% of pancreatic cancer will die. So, if the number of deaths due to pancreatic cancer is clear, we can assume the number of these deaths as a number of incidents, because we think that almost all of pancreatic cancers will die. Okay? And another criteria is short duration between disease and death. I mean that the survival of disease is short. If I tell you that, for example, 91% of pancreatic cancers will die during 1 year. Yes? And also, I tell you that the case fatality rate of pancreatic cancer is 90%. So you can say that if I have the number of mortality from pancreatic cancer during 1 year, I can assume that the incidence rate of pancreatic cancer is the same. Why use mortality rate instead of incidence rate? Because mortality is a hard outcome. It is easily detectable. Yes? It is easier to understand the number of mortality instead of the number of incidents. So in this situation, we can use the mortality data as a proxy of incidence. Two important criteria. One, the case fatality is high. Second, the survival is short. Okay? Problems with mortality data. Most of our information about death comes from death certificates. Do you know what is death certificates? The letter that has been filled by a medical doctor, okay? And we can record the cause of that mortality, okay? But if I, as a physician, are not sensitive enough to record the actual data and write wrongly, you cannot rely on the forms. Yes? It is so important. At the best scenario, you should make autopsy for all died persons, but it is not possible. Okay? So you should try to medical doctors, the nurses, but nurses are not responsible. Medical doctors are responsible to make it clear and write the reason of death inside the form. Okay? So, to improve the recording system, we have these kind of categorization, ICD, and the version right now is 11. Okay? International Classification of Diseases, ICD 11. You can see here, you can search it on Google, and you can see the reasons behind death, and you can clarify the death reason using these codes to make it internationally comparable, okay? But sometimes these codes, I told you that the version is 11 right now. We had, for example, the previous categorization styles. And there are some changes during this categorization. So the data during time cannot be comparable to each other. For example, if I use ICD-10 and if you use ICD-7, some codes might not be comparable. So you should harmonize these codings to each other to make it comparable easily. Okay? Here I have reviewed this slide in the previous session. I can pass it. Here you can see the role of definition of case for HIV. During this time, the definition of HIV/AIDS has changed. So the number of cases was significantly increased at that moment. It was not true. It was just related to the changing in the definition of HIV cases. So you should be cautious in interpretation of the data. We have 4 questions here. I want to ask you to concentrate and solve them, and we will review in the next session because we are behind the schedule and we want to go to the next session right now. Okay, we will review the answers at the beginning of the class tomorrow morning. Okay? The last session for today is this. Could you please make a summary of measures of mortality in 2 minutes before we, yes?
Mortality is the how much death or the percentage of people who have this who will die based on a certain
Disease.
denominator. For example, when we say mortality rate in general, we mean those who will die in this society in general, not from any specific something. When we say case specific.
And what is the denominator?
The denominator would be the total population in general.
Very good.
Mortality.
And how about cause specific?
Cause specific is when we, what's it called, take the denominator is the total amount of population, and the numerator is the deaths from a certain disease. And the mortality rate of a certain disease, the numerator is the total amount of deaths from a disease, and the denominator is the total amount of people who have this disease.
And proportionate mortality?
Proportionate mortality.
Proportionate mortality?
Yeah, when we say, for example, of the total mortality rate, 20 or 30% are from the disease X. It
Very
means
good.
this
Yes.
is how many
So
people
the
die.
denominator is total number of deaths.
Deaths, yes.
And we have another example. The total population is in a community is 1 million. 50% are women. Okay? And number of deaths from a stroke is what is the sex-specific rate of a stroke in our community?
What's
I
the
thought
number?
that you want to solve it.
What's the number on top?
Huh?
I can't say it.
This?
Yes.
1 million.
1 million.
For what?
Population.
Total population. Okay?
So what we have?
50% of this total population are women. Number of deaths from a stroke is 1,000. And 30% of deaths is related to men. Huh?
These 30% of this 1,000 is related to men.
Yes.
Yes.
300. 300.
Could you please solve it here?
Yeah, exactly. Questions.
The sex-specific mortality rate from cancer.
That means that the women more
Sex-specific mortality rate. What is this?
that's the difference between death between women and men. That's So
If I ask you about, if you remember, I told you that we have different type of total mortality. Cause specific, sex specific, age specific, and I showed you a slide in which I targeted children younger than 10 years old. Okay? And I told you that if we want to calculate the mortality rate among specific age, we should put the number of population at that category and use the number of deaths among that category as well. Here, I told you about sex specific.
yes,
It means that the numerator is different for men and women.
yes.
Our total population is 1 million, and 50% are women, 50% are men.
500,000.
So the population of men is 500,000 for men and 500,000 for women. On the other hand, we know that the total number of deaths
10,000.
of a stroke is 1,000. And I told you that 30% of deaths is related to men. It means that 300 is related to men and
700 to
700 is related to women. So these are two sex-specific rates in
Yes.
men and women. Okay? Is it
Yes.
clear?
It's very easy.
Okay. We have reviewed some measures, but how we can define, we can calculate these measures? How we can find that if there is any association between, for example, a risk factor or a disease? We should develop some studies. From this session, we want to review different type of studies that we can develop and explain our situation regarding different diseases. Okay?
Okay.
This slide shows you the different types of studies. We have two main categories of studies: descriptive studies and analytical studies. What is descriptive?
Describe.
The name is clear. You should describe some population. For example, how many men do we have? How many women do we have? What is the mean age of this community? What is the mean age of that community? What is the educational level of population who have disease or who are not diseased? Okay, it is a kind of description. But when we want to do some tests for relation, for example, if there is any association between smoking and diabetes or not, if using more salt can increase the risk of stroke or not. All of them are analytical, and we should have a specific design to answer to these questions. Okay? In descriptive studies, we have three important studies: case reports, case series, and ecological studies. For analytical studies, we have two main categories: observational and experimental. In observational, we just observe the study population. We do not have any intervention. But in experimental studies, we have some intervention. What do I mean? For example, having some medications. We can, for example, use some new medication for one group and standard medication for the other group and compare these two groups with each other. Okay? We are reviewing all of these study types in the future, in the next sessions. But here, today, we are going to review descriptive studies. What is this? It is level of evidence and study designs. It means that each study has its own power, its own level of evidence. When you are going to the top of this pyramid, the level of evidence is higher. It means that these types, the level of evidence is higher. It is the most strengthened and most strong disease, and it is the weakest. When you are going to the top, the strength is increased because the level of errors is decreased. Okay? At the bottom of this pyramid, you have animal studies, laboratory studies. You have not rely on these for human. Okay? After that, you have case report or case series, narrative reviews, expert opinions. These studies have no design, just description. But after that, you go to primary studies, case control studies, cohort studies, and experimental studies that we name them as randomized control trial. When you are going to the top, the level of evidence would be higher. Okay? After that here, we have secondary studies. These are not original studies. You can just use the original studies, the result of original studies, and pool the results to each other, compile them together to provide unique results. For example, there are 50 studies throughout the world that consider the association between smoking during pregnancy and low birth weight. For example, 50 studies. 30 say that there is no association between smoking and low birth weight. 10 say that there is a direct association, and 10 that there is a negative association. What is the main result? You can use those 50 and compile them statistically to find the final result. It is the highest level. Okay? Descriptive studies. Descriptive epidemiology tries to answer the questions regarding the following: time, place, and person. It means that we should answer to the question of when, where, and who. Okay? But we never try to answer why question. Why? Because it has no design. The strength is weak. We cannot say anything about why, for example, smoking increases the risk of a stroke or something like that. Okay? It aims descriptive study aim to present existing data and always starts with a list of cases which is usually entered into a spreadsheet programs. For example, the existing data that is available in hospitals, in health centers or something like that. you can describe and use this data to explain what is happened in your community. Okay? You can use tables or diagrams to explain and to show the descriptive data. What is the difference between tables or diagrams? When you use tables, when you use diagrams? Huh? Do you know what is the difference? Please assume that you want to present your thesis result
It saves time.
5 years later.
It saves
5
time
years?
and it is easy to understand.
No? You can defend your thesis 5 years later. Yes.
A diagram is for a presentation or something for the general public because it's easier to understand. But a table is for more scientific approach and also it's more accurate. So it's more for your peers, your scientific peers.
Very good.
And also, if easy to understand, it saves the time. It's table and diagram saves the time, and it is also easy to understand.
Very good. Very good. Diagram is easily understandable. Yes? But table is more accurate because when you have many information, you cannot show them in diagram, but you can write them in details in the tables. Yes? Here you can see two types of graphs. It is bar graph, bar chart, and it is a line graph. When you have different categories, for example, men, women. For example, 3 different categories of ages. Okay? You can use bar graph. But when you have several points of times, it is not understandable if you use bar chart. It is better to use line graph. Yes? And you can show the trend in using this line graph easily. So there is a difference between using bar graph and line graph. So you should be cautious to use appropriate tool. Case report, case series, ecologic studies, and cross-sectional studies are among descriptive studies. Why it is highlighted in red? Because it has 2 directions. It can be descriptive and can be analytic based on the objective that you are going to find. We will review in the next session. It is analytical and also descriptive. What is case report? Report the case. It is easy. Information about a case. Yes? Please think about a situation in which you have a very strange case with a very strange symptoms, and you have so many experiences in confronting this issue, and you want to publish your experience and have advice for your colleagues throughout the world. For example, I had a case of, for example, that disease, and the symptoms were so strange. I did not know anything about the disease. I did, for example, some lab tests, etc., etc. It is case report. But when you are going to explain different types of case and several cases are reported in a one paper, it is a kind of case series. Yes? There is a difference between case report and case series. Case series are reporting more than one case and some groups that are related to each other, considering symptoms, signs, and the activities that you have done to make a diagnosis or make a treatment for them. Okay? So, case report and case series are now. One of the most important examples of case report is acquired immunodeficiency in an infant and the route of transmission. Because at that moment,
Can we say that number of case code is a number of case code is a series of code?
no, in case report, we can explain one case. But in case series, it is one published article, but in that article, you explain a series of patients. For example, we explain 40 patients that were similar to each other, and we can explain all 40 patients in one paper. It is a kind of case series studies.
It's collection of case reports.
Huh?
It is a collection of case reports.
Yes, it is a collection of cases, not case report. Case report is a
It's
is a
about
kind
different
of study that targets one case. But in case series, you target more than one patient. You target several cases with
more patients suffering
similar-
from same disease.
very good, very good. In case report, you report a detailed description of disease occurrence in a patient, and you can provide a new hypothesis about the causes or mechanism of disease. One of the most important examples of a case report is finding the route of transmission in HIV. At that moment, before this case report, the route of transmission for HIV was just sexual transmission. The scientists didn't know anything about the blood transmission of HIV. But a physician saw a patient, an infant, that was born with RH incompatibility. Okay? But based on that disease, 18 blood donors took blood and they received blood from 18 donors, Okay? After 6 months, that infant started to develop some opportunistic infections. That was so strange because that infant was healthy and the mother and the father were healthy too. It was strange for physician. The opportunistic infection has frequently happened, and the reason behind it was not clear. After a while, one of those 18 donors has died based on HIV/AIDS disease. And physician made an examination by blood test and found that the T-cell count of that infant was low. So thought that he has HIV/AIDS as well. So they thought that because of blood donation, he received HIV. He infected by HIV. So the other route of HIV transmission was diagnosed as blood transfusion. Okay? Is it clear? It is a kind of case report. If the case was not reported, the hypothesis could not be raised. Okay? So it is case report. How about case series? Another example is related to HIV/AIDS as well. Discovery of HIV from the origin in the United States, they're related to a case series. Because there was no information about HIV/AIDS at that moment. Healthy, but they had frequently pneumocystis carinii pneumonia. It is a kind of opportunistic infection. It was strange for physicians. What is the reason behind this pneumonia in those men who were healthy in appearance? But they made some tests, blood tests, and they found that the T cells were decreased, the number of T cells in those men were decreased, and they thought that it is a kind of virus. It was no information about HIV at that moment. They tried to find the similar characteristics between those men. They searched and asked many information, many questions, and they found that all of those men were homosexual. They thought that, yes, it is related to these characters. But they didn't know anything about HIV at that moment. They tried to find the reason and did many tests, many examination, and after a while, the virus, the HIV virus, was identified. Okay, it is the result of a case series to lead to discovery of HIV/AIDS at that moment. Okay. You can see here the result of that case series that has been published in New England Journal. That is a very high prestige journal. It is just a descriptive study, but it leads a publish in New England and a discovery of HIV/AIDS. So it is simple, and I showed you that the level of evidence in that study is very low, but the result might be so significant. Okay? So the main objectives of case report and case series are providing information, sharing information for the other scientists and physicians. Advantages: key hypothesis generating tools. It is simple, it is inexpensive, easy to conduct, but disadvantages: the lack of a comparison group. You do not have a comparison group. You must describe some patients. The limited external validity or generalizability, the results that come from descriptive study, case report study cannot be generalizable for the other countries. You share just your experience. It might be incorrect in the other setting. For example, a patient with fever, with low T cell count or something like that might have another diagnosis in the next case. But you just share your experience. And the bias selection of cases, it means that you do not go to the patient. Patients are coming to your office or to your hospital. So some people, some patients who are at the other sides and who do not come to your office may be different from the patients who came to your office. So it is a kind of selection bias because that patient could not be representative of the other patients that are available in the community. So these are advantages and these are disadvantages of descriptive study as case report and case control. You can review the other slides, the other remaining slides, 15 minutes at the beginning of the next session. We will review those 4 examples and we will review the next slides, and after that we can continue the other remaining subjects. Okay? We will review case control and also court study in the next session tomorrow. I mean, okay? Do you prefer to have the class before lunch, for example, at 8 to 12, 12:30, or from 10 to 12 and after lunch?
No, no.
Which
And
before. Okay, so we